All right, when you're ready, you can go.
Hey, it seems to say they're still waiting in the lobby? No?
They are in the lobby. It says waiting in the lobby.
Oops.
Yep.
Admitting.
Thank you. Good. Hi to everyone today, and thank you for joining us for our collaborative webinar series brought to you by Rural Health West, Rheumatic Heart Disease Registry as part of the WA Country Health Service, Heart Support Australia and ACRA. I'd like to start by acknowledging the traditional owners of the lands where we meet. I'm on the land of the Whadjuk people of the proud Noongar Nation. I extend my respects to any Aboriginal people in the room today, and I acknowledge that we must stand beside Aboriginal people to restore pride in the past and the present so we can together inform the future. I also acknowledge Aboriginal people's courage, resilience, and gentle spirits. During the webinar, you will be placed on mute, so please put any questions in the chat function and we will address them along the way, and you can come off mute at the end to ask questions in person. We will have an evaluation at the end. It's 6 short questions, and if you provide feedback, you'll go in the draw to win $100 Coles Myer voucher. So good idea to provide some feedback, especially about what you might like us to speak to next year. So it gives me great pleasure to introduce today's speaker, Dr. Christian Verdicchio. Christian is the CEO at Heart Support Australia. He's a clinician and a researcher with extensive experience in exercise, in cardiovascular disease, and in sports cardiology. He brings a wealth of knowledge and experience in cardiovascular disease, governance, corporate management, stakeholder relations, and strategic advocacy to his leadership at Heart Support Australia. So I will pass you now to Christian for his presentation. Thank you.
Wonderful. Thank you for that introduction, Helen. It was very kind. And sorry if it's cut out a little bit. Some reason I left the meeting and I've just come back in. So I'm hoping that everyone can see my screen. Is that correct? Yep, great. So I think we'll just go and get started from here. So hit the next slide. So basically today's presentation is talking about the role of peer support within cardiovascular care. I guess we talk about a lot of things really around cardiac rehabilitation and these type of important aspects that are traditionally clinician-led, but we don't kind of think about what can kind of happen out in the community from people who have been there and done that through consumers. So I'm very thankful to be here. So I'll just go through some notes. So we know that cardiovascular disease is the leading cause of death and the biggest burden of the healthcare in Australia and the Australian healthcare system. More than 4 million Australians are affected by cardiovascular disease. It results in 1 in 4 deaths. To think that 25% of the deaths in Australia are attributed to cardiovascular disease kind of speaks volumes. And it's the leading cause of death in males and the second leading cause of death in females. And one interesting stat that came across last year in a conference I attended is that from a female perspective, I always think this one's actually quite interesting, and that is a woman is 10 times more likely to die from cardiovascular disease than she is from breast cancer. And if you think about, and this paper actually did some stuff around perceptions of females on what they thought was more deadly. And so you think around these pink ribbon events, breast cancer, very gender specific, and it got a lot of attention. But in actual fact, to think that it's the other way around is actually quite concerning. So I just thought I'd kind of leave that there on that point. This doesn't have to go again, a summary on what I basically said around being the leading cause of death. And obviously something that I really wanted to kind of stress around here with the bottom 3 points, and that is it's the leading cause of hospitalizations, and it's increasing yearly at around about 2.2 or more than 2%. We know that if you're a male over 55 years with 2 or more risk factors, which is not hard to have, cholesterol, family history, there's 2, physical inactivity, there's another one, adds up very quickly, hypertension, smoking, you add them to the list. You are 6 times more likely to die from cardiovascular disease by the age of 80 than if you had 1 or no risk factors. And for a female, if you have 2 or more risk factors, you're 3 times more likely to die by cardiovascular disease by the age of 80 than those with have 1 or no risk factors. So it is really, really a significant burden and an issue for people to really address. Cardiovascular disease, we kind of have those non-modifiable risk factors and we have those modifiable risk factors. We can't change our age despite how much we try to. We can't change, we can kind of change gender these days, but but genetic factors, our family history, we can't change who our family members are. We can't change our race and our ethnicity. So there are things that are locked in for us, and that's just the way it is. But that's only 3 or 4 risk factors. When you kind of think about the modifiable ones, we have, hypertension, so high blood pressure, which could be, also attributed to smoking. So there's 2. Diabetes, definitely lifestyle, type 2 diabetes, definitely lifestyle, modification-based risk factor, physical inactivity, obesity, high blood cholesterol. We haven't factored in high alcohol intake in there either. So we're looking at, 7, 8, obstructive sleep apnea, which is a modifiable risk factor as well. Once you take your CPAP therapy, that's actually quite controlled for. So there's actually 8 modifiable risk factors that we can control for. So if you're a betting person, even if you're from a primary prevention, so you haven't had a cardiac event yet or a diagnosis, odds are, if we can achieve 8 out of 4, what's the biggest number? Or 8 out of 2, depending on the individual person. Or if you have had a cardiac event and have been diagnosed with heart disease, whatever condition you have, again, identifying the modifiable risk factors are really important for long-term outcomes. When we're looking at kind of the continuum, the patient journey, we know cardiac rehabilitation is really, really important. We talk about it a lot. I actually don't like the term cardiac rehabilitation personally, even though I'm quite heavily involved, and I think it needs another term these days. But when we think about what's involved in it, so, unfortunately, again, only 10% of patients in the whole kind of cardiovascular world in hospital actually attend cardiac rehab for all the other barriers that we already know about. But, nutrition, weight management, blood pressure management, lipid management, diabetes, counseling around smoking, cessation, physical activity and exercise training is really key in these ones. I mean, this is really an exercise intervention with, counseling around diet, and other areas which all benefit each other. And we know that this is a big, really important piece of the puzzle, because if we can get on these type of things, patients can feel comfortable with engaging in these really, really kind of, I know I was always quite aggressive in my training, but intense exercise sessions, weight loss targets, perhaps, help with diets and nutrition counseling, all these things, we can actually have some significant benefits. And we know that mortality improves. We know that rehospitalizations decrease, and we know that we get a reduction in repeat events if we're actually able to go through these type of programs and actually improve cardiorespiratory fitness and achieve weight loss and start to target those risk factors. On the flip side as well, we increase, our exercise capacity, our risk profile improves, and we have an improvement in our quality of life long term. So, these type of interventions are really, really key to help patients get them back on track and show what they're actually capable of, whether you're young or whether you're old. I've seen it all. But patients, whether they have AF, whether they have a stent, a bypass, can be exercised and can undergo these type of interventions quite aggressively and cope very, very well for themselves. But then when also you think about kind of the patient journey, so, ideal sense, they have perhaps cardiac event, go to the hospital, do the cardiac rehabilitation and, continue on. This is a paper that I actually saw as a part of going through this, and part of the blurriness from it was actually how the paper actually read out. But it kind of looked at the patient journey from a diagnosis, post-diagnosis, and long-term follow-up, and kind of, what's kind of ideal sense, what happened, what are the feelings of the patient, what's the treatment pathways, and what it spoke about at the bottom is around the patient empowerment needs. Kind of got some patients to provide input around what they needed. And what's important around the long-term follow-up is that attending support groups and patient associations to maintain healthy habits was actually highlighted in there. And actually on the diagnosis part, providing support for patients' family to learn about the process and assist with recovery and assimilation was also listed. So when they actually got patients to actually talk about, well, hang on, here are typical phases of the patient journey. What do you think is important? Straight to mind, peer support comes out of this. And it's something that's getting a lot of attention lately, not just in cardiovascular disease, but in general in other disease cohorts as well. So as we know, the patient journey can be quite complex. I think sometimes clinicians maybe take it for granted, but being on the side of a patient group, it can be quite complex. And when you kind of hear patients talk about what they went through, how they went through it, the confusing information they received, it's not an easy system. And maybe for us who are in this room, if most of the people are clinicians, then maybe for us it's easier. We have some level of engagement. We've got some level of health literacy. We have friends or perhaps cardiologists or whoever that might help us. So, we navigate the healthcare system perhaps maybe as a VIP, I'll say, but, the standard patient doesn't. And there's a whole range of complexities and different patients that go through. So, you have a life-changing event. You have a heart attack. You faint, you collapse, you go to hospital, and you know what? It's just a stent. Now, okay, we say it's just the stent, but it's a stent. And they leave the next day and they're told to go home. That is really confronting for a patient. That is, hang on a second here, you're telling me I'm okay and I go home, and yesterday morning I collapsed to the floor and I had a heart attack. It can be a very confronting experience. And probably if I had a heart attack and I experienced that, I would probably be too. And I'm very much involved in this sector and I would still be scared. So it's quite confronting to kind of think that, and to be kind of told that, if they don't have a cardiologist yet, they're a newbie to the system, that they should go catch up and see a cardiologist privately, or they should go back to their GP, or they can come to the outpatient clinic, perhaps if they feel that they're a public patient, and I'll get to that in a second, they don't have a private cardiologist, and they need to go and wait for their review by the outpatient cardiology practice. So it can be kind of well, hang on, what do I do next? The public versus private patient conundrum. Public patients are unaware that they can actually access private cardiologists. This is a fact. We know that public patients think that because they're a public patient, going to see a private cardiologist is not possible. We actually know that's not the case. Private hospital cover, private health funds actually cover hospital visits and hospital admissions, and obviously, those elective-based surgeries. And if you'd kind of say if you're having a bypass or a stent, they're emergency anyways. Even if you were a private patient and you're being rushed to emergency, you'd probably be doing it in one of the large public emergency departments anyways. Some of those appointments we know that can also be pre-planned, perhaps, and so that's your luxury of having a private patient to kind of choose specifically the person they want to operate on them. But at the end of the day, if you want to go see a cardiologist or any specialist outside for a consult, that's only Medicare that bills that, nothing else. So a patient can go have a private cardiologist. The question will be, does that patient, if there's something requiring to go back into hospital, they would have to be triaged through the public health system, and they obviously don't have the choice on what cardiologist or surgeon they pick, etc. But they can still have a private cardiologist, and one obviously bulk bills. So again, issues around that. Who do I go see? If I'm a public patient, do I just wait to see what I get in the outpatient clinic? Do I not? We obviously know that there's a GP and primary care issues. Not all patients have standalone GPs. They go to super clinics. Every time they go, there's a different GP that sees them. So they typically may not have a standard GP that they see. Appointments are limited, so very busy to get into GPs at the moment, so it's very hard to come by. So that's another issue there. And GPs also, some of them may not be across some of the latest guidelines and updates in cardiovascular disease management. So again, some of these patients, I've been told to go back to my GP for further investigation or, follow up in relation to perhaps the medications I'm on and go get a referral to a cardiologist. I'm in la land at the moment because, well, hang on, I don't have a GP. I see a different one every time. I typically go for coughs or colds. So, again, this is not a straightforward process. But then if you factor in the lack of referral opportunities into cardiac rehab, we typically know that only 30% of patients in hospital are offered cardiac rehab, and then 30% of them accept it. So then you're about 9% of patients who actually take up cardiac rehabilitation. And then typically, those patients that are offered cardiac rehab are always most likely the acute coronary syndrome patients. So the AF, the heart failures, the valves, they typically get missed because, again, for whatever reason, the feedback we always get is around there's so many patients as it is. So they just prioritize acute coronary syndrome patients for cardiac rehabilitation, where we kind of know the evidence is good for all those conditions and they should all be referred no matter what. And then obviously limited time focusing on patient needs. The healthcare system is so inundated with cardiovascular disease patients and others that once they're medically stable, they're pushed back into the community, told to follow up on their own. So if we go back to that first point up on the top, that I've just had a stent yesterday, I have no idea about heart disease, I have no idea about healthcare, and then I have all these questions afterwards. It's a very, very hard system to kind of navigate and get your head around. And it's quite possible that you may spiral out of control with some other type of, feelings and emotions that are quite negative and, can actually go down a pathway that's not that quite positive. So I think it's important to really understand that, patients may be anxious, worried, depressed, isolated, confused. And, it can really be hard for them to kind of navigate this road. So I just kind of put this together based on feedback I've had when speaking to people, but these are just some possible patient journeys. You can go to the hospital, you go to cardiac rehab, you go back to your GP, you may be public, so outpatient cardiology, GP review. You may go hospital, cardiac rehab, GP, private cardiologist, GP cardiology reviews. You may go hospital, you may not get cardiac rehab, you may get internet after outpatient cardiology and go and look at what's on the internet and then go to a GP super clinic and see somebody. There are a whole range of ways in which the patient journey can take place. And it's a whole range of things because of where that patient lives, what their socioeconomic status is, obviously, what their health literacy status background is, their ability, to fund these type of initiatives, whether they're public or private, whether they have to go back to work, what their personal mental health at that point is as well. They've already got a whole range of other things happening in their life and then confounded with this. So there are a whole range of possible patient journeys. So it is not a one size fits all, as much as we like to think that is the case. And so the realities is that there's different pathways, there's mixed messages. You got the public and private situation. You've got no real individualized support. You have different doctors. GPs are busy. You have lack of outpatient support programs after cardiac rehab. And so the longer term effects that take place once there is no support anymore. And so that is quite the case. Even if in an ideal sense that you were one of the lucky ones that went through the process and you had cardiac rehabilitation and you even had a private cardiologist, that time frame to typically complete cardiac rehabilitation program to go see that could be over 2, maybe a 3-month period. Now, that's all pretty good. You're getting seen by someone regularly, you've been spoken to and you feel comfortable. But all of a sudden, imagine after 3 months though, where you kind of feel, okay, things are getting better, I'm feeling okay. And then all of a sudden the cardiac rehab go, you're done. And the cardiologist goes, yep, you're fine. I'll see you in 12 months for a review. And then all of a sudden you're left on your own. and all of a sudden, all the issues and stuff that you haven't really had a chance to kind of process start sinking in, and you start to have some questions, and you go for a walk one day, and you feel a bit huff and puff, and you got a bit of, palpitations, but it's actually nerves, and then that gets worse. And then all of a sudden, you don't have anyone around you, and almost, I like to say, that FOMO kind of kicks in, where you don't have anyone anymore to ask. You don't have that nurse, you don't have the exercise physiologist or the physio, you don't have going to the cardiac rehab once or twice a week, knowing that you could kind of buffer off somebody and talk to. You have nothing anymore. And you go back to your GP, and 6-minute appointment, not much from that. And they say, well, you're fine, go back to the cardiologist. Cardiologist, like, well, there's not much here to do. You're quite fine. Where do you go? And so, that's where kind of the role of peer support comes into this. And it's really designed to kind of, those longer term effects that take place once there is no support anymore, it's designed to fit in there nicely. It's not designed to be a clinical program. It's not designed to be cardiac rehabilitation. It's not designed to replace your doctor or your nurse or none of that. It's designed to provide support and where all the kind of traditional pathways are exhausted, and that there's nothing there anymore to help a patient in the longer term recovery of their cardiovascular disease diagnosis. And obviously, it's, these things that we typically see with patients that do come into peer support programs. They're worried, they're scared, they're anxious, depressed, start to back off socially as well. And that's quite normal. I mean, there are times where I felt down, you can't be bothered talking to people. So, negative feelings. And then obviously the worst one that I always used to see in my clinic was feelings of needing to slow down and do less, which is even worse because you become even less, you reduce your cardiorespiratory fitness and your general, functional capacity even more. And so you're actually doing even more of a detriment to yourself. So it really is an important piece here in terms of, what happens after that pathway kind of takes place. So what is peer support? It occurs when people provide knowledge, experience, emotional, social, practical help to each other. It's distinct from other forms of social support, and that is the source of support is a peer. So that's what is unique about it. Someone who is similar in fundamental ways to the recipient. Been there, done that. There's an equal between us. We don't have to pick to say, oh, you had a stent, I had a bypass, we're different. No, you're not. You've had similar experiences. You're probably in similar classes of drugs. You had heart disease. There's the commonality. You have heart disease. And believe me, these people find the link because it is all scary. Whether you have valve disease, whether you have AF, whether you have a stent, whether you have bypass, they are all scared in heart disease. And it's very, very important that this link is the key. It is not clinician to peer. That's one thing saying, I'm a clinician, I've done this, 2,000-3,000 times, you'll be fine. That messaging is also very important. But it's incredible what a peer can do to another peer and the conversation they can have very quickly. So yeah, obviously I've just covered that point, what I said just now. The benefits of peer support, a sense of belonging and support to consumers with heart disease by sharing experiences with each other, what they've been through, educating one another to manage their heart condition best. So ultimately, they'll end up back in hospital or worsen in their physical and their mental health. It is widely known or reported that, attending peer support can help with quality of life, adherence to medications, especially by telling, when these kind of discussions come up, saying, look, go back to your GP, go back to your cardiologist, have a discussion. Sometimes it has come up in groups where people said, oh, I stopped this tablet because it was making me tired, which we all have, I'm sure we relate to. And the comment was, well, actually, no, and we educate our volunteers to say, well, actually, no, medications work with other medications for a reason. And so it's important to actually go back to your GP or cardiologist to talk about that instead of self-medicating or self-ceasing, because it may have other effects on the body. So please go back, don't follow the plan as it is, but go back and have a discussion with your GP or cardiologist first, because they might be able to put you on something else. And so educating people, reminding them, say, hang on a second, okay, you might be unhappy, but just go along with the flow for now. and go back. And then some people may jump in and be like, actually, I stopped my meds and my blood pressure went through the roof. I ended up back in hospital a week later and I thought I was feeling better. Then boom, one day it came back. That experience can make the penny drop for somebody else. So we can't underestimate that. Improve mental health, improve psychosocial outcomes. We're seeing unnecessary appointments, reduction in unnecessary appointments take place because people are doing the right thing. They don't need to go back to their GPs. They don't need to go back to their cardiologists unnecessarily. People are talking about, I'm starting to feel a bit of, should I go back and should I call my GP? No, well, actually, we had a stent too, and we had the same thing. And after a few weeks, it actually settled down, it was quite normal. Okay, a few weeks go by and actually it took place, or perhaps it doesn't settle. It's like, okay, it's been a bit longer now. What do I do next? Well, maybe you should go to your GP. So there are times where, very important that those discussions can help that patient as well. And obviously just an improved understanding of the heart condition and obviously empowering that patient to really take control of their condition. And kind of one example, I like to think of peer support, because obviously I've been a dad, a wife, for 4.5 years now, our little one, and then 2.5 years our other one. The example I like to use is a mother's group. And if there's any women on this call now and mothers themselves, my wife went through the mother's group, and it was the best thing. And when I kind of came into this role with Heart Support Australia around peer support, I kind of realised that this is a mother's group for heart disease. My wife going to a mother's group, talking to mums who've been there and done that, my kid's not breastfeeding or this and that, she would come back and feel less stressed, and, to know that speaking to others who have been through that situation as well and kind of having a, coffee over it and talking, that's exactly what we're trying to achieve here. It's really the nuts and bolts of peer support and what we're trying to achieve with Heart Support Australia. So I guess on that note, I'll kind of go through around, who are we at Heart Support Australia and what are we doing? And we're, a peak national body that provides support and advocacy for Australians who are impacted by heart disease through peer support. We're a consumer patient organisation providing support, encouragement and education to heart disease patients and their families. And ultimately, our vision is to stop secondary cardiac events and improve the lives of those living with heart disease in Australia. And when we kind of think about our mission, it's kind of true to what I've just said, is around facilitating that transition from hospital to home and providing that ongoing support for heart disease patients, whether in regional Australia or metropolitan Australia. Our peer support programs are patient-centred to long-term care. So our peer support programs are really there to bridge the gap in the assessing of specialists, hospitals, cardiac rehab, mental health services, particularly in remote regional areas. And we know that obviously what I've just spoke about in the presentation, that many patients face a lack of comprehensive care from busy GPs, or leaving them unsupported post-diagnosis or treatment. So it does fill that void, as I was saying, around what after a cardiac event, what after a cardiac diagnosis. Our peer support groups. So we have two arms to our program. We have peer support groups. We have about 25 of them across the country, who are led by cardiac consumers themselves, trained by us, overseen actually by Helen, who's on this call today as our national program coordinator. And the groups are there to foster a supportive atmosphere for sharing experiences and information. The groups collaborate with hospitals, cardiac rehab locations in particular, because we understand a lot of people who finish up with cardiac rehabilitation may want something afterwards, and typically those nurses and the staff in those locations know best to push, help promote those patients to go into peer support afterwards. And in terms of, the groups, these are monthly groups that are about an hour and a half in duration, which allow the opportunity for some education, because we have handouts, designated education topics every month, because it's really important to reinforce the messaging from the hospital, from cardiac rehabilitation, or from clinicians around, take your medications, don't stop them, keep exercising, here's some information to keep going, reinforcing that messaging over and over again. And then also at the same time, allow ample opportunity to sit down and actually share experiences with each other. And that's really what's important. And the beauty about our program is that people can come for as long as they want. It's free, it's accessible. And we have people that after, a while start to attend, because maybe for them it's not so much a big benefit, but it's their experience that they can help others who are coming through the group as well. So that's also what's also unique in terms of this setting. The other arm to our peer support program is actually quite unique, and that is we're the only cardiac patient organisation where we actually train up consumers to go into cardiac wards across the country to provide bedside peer support. And this is actually really cool. When I started, we only had 2 hospitals under agreement. We had now 15 across the country under agreement. And this is typically done in the metro locations, because that's where the cardiac surgeries and the cardiac wards cardiac wards are. So this is, we have, in Perth, this is WA. So we have Fiona Stanley, Hollywood, St. John of God. I think they're the 3 in Perth. I don't know if there was another one there, but forgive me if there was. And then in the other states, we have kind of the major hospitals as well. Like in Adelaide, we have the Royal Adelaide Hospital, and we have Epworth, Eastern in Victoria. We have the Royal North Shore in Sydney. So this is a really cool program, and the major hospitals are starting to jump on this. And what we're finding is that we're giving consumers the option that whether they lead a peer support group on a month-to-month basis, or do they actually want to go and provide bedside support? Because as we know, if you are going through the journey in hospital, that can also be a daunting experience. And I was, being in a bed, you're about to wait for your bypass operation, or you've just had the bypass operation, and you have all these feelings and emotions, and the surgeon or cardiologist comes in the morning for a few minutes for the ward round. It's a very lonely day. And so nurses are busy, they're attending to multiple patients in the ward. So having somebody, again, who can sit down for 30 minutes or an hour and talk to you, kind of let you know, what they went through. Perhaps they did the same procedure that's happened before, kind of give them that white light, what to expect after hospital. So, make sure you do your cardiac rehabilitation. I didn't do it, and, it was the worst mistake I ever made. These type of, discussions, and this can really make a big difference. And the feedback that we get from patients who actually do email us and say, thank you so much, you made a world of difference to my recovery or my time in hospital, or the hospital staff that say, thank you, like, these are making a world of difference to our patients. And we just see their faces completely change after your volunteers walk out of their room. It really can make a big difference. I wish I had thousands of these across the country. We have 15 hospitals. We have about, 50 volunteers doing this program, and we hope to continue to grow that. So that's something really cool, and another part of peer support that we offer at Heart Support Australia. In addition to that, we do lead some national campaigns and assets. So we have the Know Your Numbers, Treat Your Risk, which is a national online asset, and also printed. We have that's distributed across our programs, and also various hospitals have contacted us to actually have these assets, and it's all around cholesterol and lipid therapy of the guideline target of achieving less than 1.4 millimoles per litre. That's the guidelines now. If you have atherosclerotic cardiovascular disease, if you had a heart attack, that's your lipid target as a patient. That's all you need to know. And this asset is geared towards empowering consumers to go back to their GP or cardiologist, say, hang on, this is saying that I need to be 1.4. What are my lipids? What's my LDL? 1.8? Well, how do I get down to 1.4? Why are you not making me go down to 1.4? If this is saying that this is the international guidelines and obviously the Australian guidelines now, why is that not the case? And really empowering the patient to, drive these discussions, because sometimes we know clinicians can also be a bit, it's okay, it's 1.7, it's not too bad, or they may be, a generalist by nature, could also be a little bit behind with some of the information they're receiving. So empowering patients or empowering consumers is really important in this piece. So that's something that we're quite proud of to actually continue to do. We also have partnered. Last year, we started Australia's first Cholesterol Awareness Week. A few of us got together, and we'll be continuing that this year in our various ways across the country to continue to raise awareness of cholesterol, and we'll be kicking off this November 24th, 25th. So I got to double check, but Monday, last week of November, for 1 week. So again, something really important nationally, where we just want people to really understand that cholesterol is an important thing. And the reality is, high cholesterol is a major killer, because it doesn't present with any signs or symptoms, and sometimes it can be too late, and that person has a myocardial infarction or stroke, and the worst has already happened because they've had underlying plaque for so many years without any assessments done. So we really want to drive the awareness around that. And I guess just to kind of talk about some of the recent highlights of heart support, you know, we've achieved a lot over the last few years, and Helen's been a great member of the team as well. And we're now reaching, you know, a significant amount of patients or consumers per annum in our face-to-face programs, let alone our online reach. We have received multiple nominations and awards, or being a finalist for numerous awards for our advocacy role and our campaigns around Know Your Numbers, Treat Your Risk. We do partner with a whole range of leading research groups to provide consumer input into research, and also a range of strategic MOUs with other key partners in the sector as well. So we continue to grow and we continue to work with others to ultimately play our part, because there's a lot of people with cardiovascular disease in the country, so the more the better, really. So on that note, I'd like to say thank you for the opportunity to present today. You know, we are here and happy to play our part in any way, shape or form, and I'm happy to take any questions you have about today's presentation. So thank you.
Thank you, Christian. That's fantastic. I'll just, if anyone could come off mute, if they have a question or raise their hand or put the question in the chat, that would be fantastic. I did think to highlight the people who run the peer support groups, they've been where that new person coming to their group is. They've been there before, so they really have that sense of no judgment, and there's no power differential with them. Like you say, there's no time limit to come. So it's like maintenance phase of cardiac rehab, where you can come for as long as you like, and you can bring your carer, your family member. And it's really about instilling all those self-management skills in everyone that attends. And another point I'd like to pick up on was when you spoke about all the different pathways. Sometimes heart support are the people who pick up the people who fall through the cracks, who didn't get any cardiac rehab, went on the internet and went, and sort of made their own way, and then found a group that was close to them, and then they actually are starting their cardiac rehab journey then, and the peer support leader will recommend that they go back and get back in all the right areas. So I think that's important too. Have we any questions in the room? I wonder if Faye, one of our peer support leaders, is in the room. I wonder if Faye wanted to make any comments or anything. And I can't type in.
I think we've got someone typing in the comments section.
Good.
Oh,
good.
Thank you.
Thanks, Akasha. Yeah. Okay. And the meeting will, of course, be recorded. It's been recorded and will go up on the Rural Health website and the ACRA website. So please let your colleagues, make your colleagues aware. And don't forget to fill in the evaluation. And also within the evaluation, it's really good if you suggest presenters or presentation subjects you'd like for next year. So if there's nothing else, I'd really like to thank you, Christian. That was a fabulous presentation. And Yes, and we'd like to thank all our peer support leaders and all our hospital visitors. They do an absolutely amazing job. Thanks, Christian.
Thank you, Helen, for the opportunity.
Cheers.
Thanks, Christian. Bye.
Thanks, Taylor. Bye.